everyone, welcome back to the channel. Today we are learning about multiple sclerosis, one of the most important autoimmune diseases of the nervous system. I'll explain everything in simple and clear steps, perfect for beginners or anyone revising for exams. And don't forget, the complete notes are available in the link in the description box below. Now let's start with an overview. MS is a chronic autoimmune condition, meaning your body's own defense system attacks your central nervous system. This immune attack destroys the myelin sheath, the insulation of nerves, and sometimes the nerve fibers themselves, especially in the brain, spinal cord, and optic nerves. This causes episodes of weakness or vision loss that can get better, but over time may lead to permanent disability. Now let's see who usually gets MS and what increases the risk. It usually begins between 20 and 40 years of age, and it's about twice as common in women. MS is more common in cooler, temperate regions like Northern Europe or North America. Genetics play a role, especially HLA-DRB1 alleles, which raise susceptibility. Environmental factors also matter. Low vitamin D, prior Epstein-Barr virus infection, and smoking all increase risk. Having a family history or other autoimmune diseases also raises your risk. So that's who gets it. Now let's look at what happens inside the body. In multiple sclerosis, autoreactive T cells cross the blood-brain barrier and trigger an immune attack involving B cells and macrophages. These immune cells release inflammatory cytokines that destroy oligodendrocytes, the cells that make myelin. This leads to demyelination and nerve damage, forming hardened scars called plaques. That's the sclerosis part. These plaques are commonly seen around the optic nerves, near the brain ventricles, and in the cerebellum and spinal cord. Because nerve signals slow down, neurological symptoms appear, flare up, and sometimes improve again. Now that we understand the mechanism, let's look at the different forms of MS. The most common type is relapsing remitting MS, with clear attacks followed by partial or complete recovery. Over time, RRMS may turn into secondary progressive MS, where symptoms gradually worsen. Primary progressive MS means slow, steady decline from the start without remissions. And clinically isolated syndrome refers to the very first attack that looks like MS. It may or may not progress later. Now let's go through the typical symptoms seen in MS. Optical neuritis is a classical sign, painful vision loss in one eye with reduced color vision. Sensory symptoms include numbness, tingling, or an electric shock feeling when bending the neck, known as Lermite sign. Motor signs are limb weakness, stiffness, overactive reflexes, and a positive Babinski sign. If the cerebellum is affected, patients may show ataxia, tremor, and slurred speech, known as Charcot's triad. Autonomic symptoms include urinary, bowel, and sexual dysfunction. And many experience fatigue that worsens in heat, called Uthoff phenomenon. Next, how do doctors diagnose MS? MRI scans of the brain and spine show multiple white matter plaques, often shaped like Dawson's fingers. If the lesions light up with gadolinium contrast, it means inflammation is currently active. Spinal fluid shows oligoclonal IgG bands or an increased IgG index. Both confirm immune activity in the CNS. Evoked potential tests detect lower signal transmission in visual or sensory pathways. The McDonald Criteria are used to confirm the diagnosis, showing lesions at different times and locations and ruling out other causes. Now let's talk about treatment, both for attacks and long-term control. Acute relapses are treated with IV methylprednisolone 1 gram daily for 3 to 5 days. If symptoms don't respond, plasma exchange or IV immunoglobulin can be used. Symptom management is also key, like treating spasticity, pain, or bladder issues. The long-term goal is to reduce relapses and delay disability. First-line drugs include interferon beta and glatiramer acetate. Oral agents include dimethyl fumarate, teriflunomide, and fingolimod. For more aggressive cases, monoclonal antibodies like natalizumab, ocrelizumab, or alemtuzumab are used. Patients are monitored regularly with MRI to assess treatment response and safety. Now let's cover rehabilitation and supportive care. Physiotherapy and occupational therapy help maintain mobility and independence. Exercise and energy pacing reduce fatigue. Cognitive and emotional support help manage memory problems and mood changes. Patients should avoid overheating, manage stress, and treat infections early. Vaccination and vitamin D supplementation are part of long-term preventive care. Now let's look at the prognosis, what the future looks like for someone with MS. Multiple sclerosis varies from person to person, but most people live a normal lifespan with occasional disability. Better outcomes occur in women, younger patients, and those with sensory symptoms and long gaps between attacks. Poorer outcomes happen with motor or balance symptoms early on, frequent relapses, or a progressive course. Early treatment with disease-modifying therapy and regular follow-up greatly improve long-term function. Now, let's summarize everything we've covered. In summary, MS is a chronic autoimmune disease that damages the myelin in the central nervous system. MRI and spinal fluid findings are essential for diagnosis. Steroids manage relapses, and disease-modifying drugs slow the disease. Rehabilitation and good patient education help maintain independence and quality of life. Thanks for watching. Don't forget to like, subscribe, and share the video, and check the link in the description box for the full notes. See you in the next one. Bye!